I work at Center for Spinal Disorders, which is a division of OSNA. Did my training at Walter Reed Army Medical Center and in San Francisco, California. The spinal fusion is a surgical technique that we use to stabilize the spine and restore its alignment. And it's used if the spine is unstable for any reason. Spinal instability can be defined as two bones in the spine moving in an abnormal way, or perhaps two bones in the spine that have taken a position that's abnormal and causes compression on the nerves. Spinal fusion is a technique that joins or fuses two bones together, and it does that by using your body's own healing mechanism for broken bones. Some of the older techniques for spinal fusion are criticized because of the amount of soft tissue dissection, which means the muscles and the ligaments and so forth around the spine, and the pain that can result from that. So as a result of that, surgeons have looked for less invasive techniques for spinal fusion. Surgeons have been developing techniques that are less invasive, that disrupt less muscle, and the lateral interbody approach is one of them. There was a standard, and still is a standard open approach from the side where we make a longer incision and go through the muscles. The lateral interbody approach is only 1 or 1.5 inches long and goes down to the spine through the side, getting to the front half of the spine but from a side direction, and places an implant or spacer there to lift the bones up, restore height, restore alignment, and bone graft or other material in the spacer to get the bones to heal and fuse together. Nerve injury is a risk of any spinal surgery, and with lateral interbody surgery, there are nerves next to the spine that are at risk. With this technology, we use nerve monitoring during the surgery to tell how close we are to the nerves or if we're causing any nerve irritation, and it allows us to avoid injuring the nerves in most cases. The overall risks of any spine surgery are injury to nerves, in rare cases even paralysis, infection, bleeding, and other complications. The risks of interbody fusion lateral approach include injury to anything that's near the spine, so major blood vessels and other structures. So it's a technique that should be used by an experienced surgeon who's experienced both with more open standard techniques and the unique anatomy and some experience with the lateral interbody technique. The decision from which particular fusion technique to use has got to be tailored to the individual patient. This technique is one tool and one way of doing the surgery, and for some patients is the best, but for other patients isn't the ideal solution. Also, what levels are we trying to do? Because the lateral interbody technique, because it must come above the pelvis, can't reach the lowest disc in the spine, and in some patients can't reach the second lowest disc. I would say about 1 out of 4 patients we can't reach the second lowest, but in all others above that it works very well. This technique can be used in patients with more complicated problems as well as just simple problems or simpler problems of just pain. I have one particular patient who has scoliosis who has had previous surgery done from the back that has not healed and needs to get a solid fusion. One of the problems with surgery from the back is a lower fusion rate or a lower success rate in some cases of spinal fusion. So in her case, we're using the interbody technique basically to reinforce her previous surgery, stabilize it and get it to heal with a much higher anticipated success rate than you might otherwise have. And interbody fusion can be done directly from the front or from the side with this technique. And in some cases, interbody fusion can be done from the back. So there are a lot of different options. This technique has the advantage of a smaller incision, a faster healing time, and generally speaking, lower risk.